All right. Good evening, everyone, and thanks for joining our men's health webinar. We are so excited to have the opportunity to share important men's health education with this group tonight. My name is Brittany, and I am the host of tonight's event. I'll start with a couple housekeeping items, and then I'll introduce our speaker. Most importantly, your participation is completely anonymous to other attendees. No one can see your face or your name, and any questions that you ask can only be seen by myself and the speaker. We encourage interaction during the presentation. So if you'd like to ask a question, please type it in the chat box at the lower part of your screen, and we'll save time at the end of the presentation to answer as many questions as we can. Tonight's webinar will be presented by Dr. Joshua Calvert, a prosthetic urologist and men's health specialist at Urology Associates. Dr. Calvert, I know your time is in high demand, and I thank you for your willingness to be with us this evening to share education with the community. I'll go ahead and turn it over to you.
Awesome. I hope everyone can hear me okay. I'm really looking forward to this. I absolutely love what I do. I love talking to men about health. I love specifically talking about these topics we're going to discuss tonight. So I appreciate everyone taking time out of their busy schedule to be here. So this is a picture of me at the end of residency. I've aged apparently poorly since that time, but I'm Josh, Dr. Calvert. I am a Northwest native. I've been in Nashville since 2016 now, trained at Vanderbilt, and then did a fellowship in men's sexual health in Salt Lake City. Now I'm back here in Nashville at Urology Associates, where I've been for going on 2 years now. So tonight we're going to talk about a couple of things. We're going to talk about male stress incontinence and erectile dysfunction. And we're going to talk about kind of what it is and your treatment options. Again, I'd like to start by thanking everybody for being here and acknowledging that as men in our society, it's often not easy to talk about our health. It's certainly not easy to talk about kind of some more intimate or potentially embarrassing aspects of our health. So I commend all of you for being here, for getting your questions answered. And again, I really encourage you to be interactive throughout this process. So first, we're going to talk about stress urinary incontinence. So this covers a schematic of how your bladder and how your urethra interact to store urine and to expel urine when it's socially expedient or when it's time. So the bladder, obviously, everyone's heard of the bladder. The kidney filters urine and it's stored in the bladder and it exits via the urethra through the penis. Part of the urethra underneath the area of the prostate is the external sphincter, and that's muscles that can collapse to close off the flow of urine and prevent urine from leaking. Very simply put, when the muscle relaxes and the bladder squeezes, that's when you expel urine from your body. So what is male stress urinary incontinence? It's bladder leakage. Stress incontinence is when the sphincter or the muscle group is damaged or weakened, so it can't stop the flow of urine. More common in when intra-abdominal pressure is increased, which is a fancy way of saying when you laugh, walk, bend, sneeze, cough, laugh, jump on a trampoline. And when it comes to stress incontinence, we mostly think of this in terms of men who have had surgery, most commonly for prostate cancer. And anywhere between 9 and 16%, so we'll say 10 to 15% of guys have some degree of stress urinary incontinence within still present 1 year after prostate surgery. And worldwide, 500,000 men have stress urinary incontinence. This slide just shows that quality of life can be affected and impacted in a host of ways when it comes to urinary incontinence. Studies have shown that people with stress urinary incontinence are more likely to be depressed, distressed, emotionally disturbed, and socially isolated. So many men have heard of and are aware and are being screened for prostate cancer. Prostate cancer continues to be a very prevalent disease in the US and around the world. And approximately 70,000 prostatectomies, what we call radical prostatectomies, are performed each year. And that's the surgery that's done to remove the diseased prostate And then as part of that procedure, the bladder and the urethra, or the tube that drains the urine, are sewn back together without the prostate there. And again, about 10 to 15% of men have persistent leakage after a prostatectomy. So this is kind of the main population that we're talking about when it comes to stress urinary incontinence. So leakage is very common after a prostatectomy. That's one of the things we tell guys prior to surgery and to expect when the catheter comes out. And most men are able to restore their continence within that first year after surgery, but not all of them do. So when it comes to the treatment of stress incontinence, there are multiple different types of doctors that can treat that. There are urologists, and urologists are specialists in the male and female urinary tract and the male reproductive organs. There's also prosthetic urologists, which is people with additional focus or training in the areas of implanting specialized devices to help with some of the problems that we're talking about tonight. So I consider myself to be a prosthetic urologist based on my additional training, as well as my area of focus within my specific practice. So these are some of the short-term options that men use or consider when they experience leakage. There are behavioral modifications like fluid restrictions or timing bathroom breaks. There are conservative interventions like Kegel exercises or pelvic floor training with biofeedback. And then there are also kind of coping methods used like pads or guards or diapers, catheters, or even Cunningham clamps, which is a clamp that you see here depicted that you put around the urethra and the head of the penis to prevent leakage. But these short-term solutions are not good at providing lasting relief. They can be expensive, they can be a nuisance. And again, as we talked about before, this problem can be very socially isolating to men. And it's something that I take very seriously in my practice and want to help guys overcome. There are two long-term treatment options available to men, and these are life-changing surgeries for men who have leakage after prostate surgeries. So the two are a male sling, and the male sling is a outpatient surgery, and it is a synthetic material that goes underneath the urethra beyond the point of where that muscle closes. And what it does is it allows the urethra to be kind of bulked up or supported to create more resistance for when the bladder is squeezing to prevent that leakage of urine. It's all concealed, and it is like I said, it's an outpatient surgery. For more severe forms of stress urinary incontinence, there's something called an artificial urinary sphincter. And it is a three-part system. We'll show you a graphical representation here in a few slides. And what it does is it replicates exactly how your normal anatomic or physiologic sphincter works. So you have a cuff that is closed, and you have a pump down in the scrotum, as well as a pressure regulating balloon that is in the abdomen. So when you want to void, what you do is you squeeze a pump in the scrotum, and that allows urine to drain. The cuff deflates, allowing urine to drain, and then the cuff slowly refills, squeezing down on the urethra to prevent leakage again. So some of the advantages of the sling is it's minimally invasive. Most men are back to normal activities after 1 or 2 weeks. And unlike the sphincter, there's no interaction with the device. So it's one and done. It's implanted, and your leakage is reduced. And it's a great procedure for men who have mild to moderate stress incontinence. The sphincter, like we said, the advantage is that it really replicates a normal, healthy, functioning sphincter and allows men to urinate when desired and reach the most amount of dryness that's possible to achieve. Again, it's placed entirely in the body. No one knows that you have it in. It's undetectable to others. All right, so this is a animation showing how the sphincter works. I love these animations. So it is going to get started here in just a second. So you can see here, it's all self-contained. No one knows you have it in. You have, as we talked about, there is a cuff that is around the urethra, and then you squeeze a bulb that allows fluid to transfer from the cuff back to the reservoir that you see depicted up here next to the bladder. The urine flows out of the body, out of the tube at a urinal or a toilet or whatever a man chooses. And then that cuff passively refills, closing off that flow of urine again. So I would really encourage anyone who's on this video right now, or anyone who has additional questions about leakage, to talk to a urologist, to talk to a prosthetic urologist, talk to your primary care doctor, and get plugged in with a urologist who can help you discuss if these treatment options are right for you, and if they can get you back to a point of having continence and some normalcy. There are obviously risks associated with any surgical intervention that are important to discuss. The major risks of any implanted device, similar to a knee replacement that a lot of men have heard of or know of or have experienced, is that if the device, because it's a mechanical device, if it doesn't work, it has to come out. If it gets infected, it has to come out. Any surgery has potential for associated pain or infection, and sometimes pain can last for a long period of time. So there are risks to any surgery, which again is why it's important to talk to a medical professional or a urologist or a prosthetic urologist about whether or not this would be a good consideration for you. Briefly, insurance is not guaranteed. Fortunately, Medicare and most private insurers will cover the sling or a sphincter. So to summarize the stress incontinence portion of this, stress incontinence is a known side effect of prostate cancer treatment and other conditions. There are a lot of treatment options. Coping options like diapers, pads, clamps, and muscle training are short-term options that can be expensive over time and uncomfortable. And some men go on to require a sling or an artificial sphincter that can offer a permanent solution for stress incontinence. So you should definitely get in and talk to a urologist or talk to me, because I love this stuff and I'd be happy to talk to any of you guys about it. All right, now we're going to talk about the part of the evening that I think is a little bit more fun to talk about, and something that I'm particularly passionate about, which is erectile dysfunction. So we're going to talk about erectile dysfunction and all of the potential treatment options. And before we do that, I want to kind of frame this conversation how I would if you were a patient sitting right in front of me. So if I am lucky enough to have the opportunity to talk to you about this in person in the future, these are some of the things that we'll talk about. So when it comes to erectile dysfunction, I think we overcomplicate it as men. Again, a lot of men are embarrassed, they're nervous to talk about it. And the reality is this is all I do all day long. So if you come talk to me, I hope that I can make it as comfortable of an experience as possible for you. But we overcomplicate it. Erections are simple. I like to think of it as a binary or dichotomous variable. It's a 0 and a 1. Okay. So I put a guy on, the reason why I came up with this way of thinking about it is I saw a lot of guys back who I would put on a oral medication. And we'll talk about some of those options like Cialis or Viagra. I'll put a 60-year-old guy on one of those medications, and I see them back a few months later and I say, hey, how's it going? Checking in. How are your erections on the medication? And they'll say, they're okay. And I go, no, which is why I came up with this idea of it being a binary variable. So it's zeros and ones. So what is a 1 when it comes to an erection? A 1 is you have an erection when you want, that's as hard as you want, that lasts as long as you want, that is a source of pleasure and confidence for you and your partner, and it's not painful for you or your partner, and it's something that you're proud of. That's a 1. What is not a 1 is a 0. So anything that is not a 1 is a 0. That's how I think about it. It's that simple. And so I think by kind of boiling it down to those basics, it makes it much easier to see, do I need to be more aggressive in my treatment? What can I do to get back to being a 1? And not uncommonly at all, when you ask guys, when is the last time you were a 1? they'll say, oh, when I was 35 or when I was 45 or when I was 22. And the reality is this is why there are so many treatment options, because there's not a guy who I talk to that if they want to get a good, dependable erection that's a 1, we can't get them there. So if that sounds interesting to you, listen on. Let's get you to a 1. So erectile dysfunction is the inability to achieve or maintain an erection. It is that your penis used to be a 1 and now it's a 0. Again, you're not a 0, but your penis used to be a 1 and now it's a 0. It is very, very, very common. More than half of men over the age of 40 have some degree of erectile dysfunction. It affects almost 40 million American men. So briefly, the physiology, simply put, getting an erection is a complicated process involving a lot of different systems, including blood vessels and nerves. So when there is arousal in a physiologic, healthy, functioning penis, the nerves become active around the penis and muscles and arteries relax, allowing more blood flow to enter the penis. And then that is what makes the penis stiff or hard when it is engorged with blood. And that erection or stiffening blocks the veins that take blood out of the penis, and it keeps the penis hard so it can remain erect. As you can imagine, with that level of complexity, there's many areas where that can go awry. So there are lots of other comorbidities that are common in men who have ED. And we'll talk about here in a few slides that ED can also be kind of the canary in the coal mine when it comes to other disease states. Like stress urinary incontinence, erectile dysfunction can have broad impacts on quality of life in general. It can be isolating. It can be embarrassing. It can cause a lot of distress for men, and I see this day in and day out. And again, I would encourage anyone who feels that way to know that you're not wrong. You're not weird. That's normal. It's normal to feel that way because we don't have the tools to talk about this. So I want to talk about a few disease states. So erectile dysfunction as it relates to diabetes. Erectile dysfunction and diabetes go hand in hand. And 1 in 2 men with diabetes have sexual troubles or erectile dysfunction caused by their disease. And in some men, erectile dysfunction is that canary in a coal mine. It can actually precede a true diagnosis of diabetes and be a sign that you're headed in that direction. Erectile dysfunction and heart disease. So again, that canary in a coal mine. ED may be a warning sign for more serious issues. The American Urologic Association, who is sort of the guideline forming entity or the governing body above all urologists in this country, has guidelines for erectile dysfunction. And they recommend in their guidelines that men who present with erectile dysfunction should be evaluated to make sure there's not an underlying cardiovascular problem because of the prevalence that ED is a presenting symptom of something worse. And again, I'm very fortunate as a men's sexual health specialist that I'm the first point of contact for a lot of patients. Well, they will come in and I'm the first one they've really talked to about their health. And if they're talking about their erectile dysfunction, again, to give you a little glimpse of what you can expect if you see me, the first thing I'll tell you is, yeah, we want to get that figured out and you're awesome and I appreciate you talking to me, but we got to get you set up with a primary care doctor. So I like to tell people when they ask, is there anything I can do to help my erections, or is there anything I can do to help so many of the other aspects of men's health that I deal with? I always say, well, the things that your mom told you to do, those are the things that are good for your heart and your full body and your erections. And that's eating a healthier diet, getting more sleep, reducing stress, maintaining your weight, exercising, being mindful, don't smoke, all those sorts of things. So another disease process that is very common in men who have erectile dysfunction is testosterone deficiency or low testosterone. And testosterone is a huge buzzworthy topic right now. It's impossible to turn on the radio and not hear advertisements for testosterone deficiency and erectile dysfunction. And again, this is something I'm so passionate about because so many men in our community and across the country are being inappropriately managed when it comes to testosterone. And that doesn't mean that I'm apprehensive about putting guys on testosterone if it's needed, but there's excellent studies that show that less than half of guys that are on testosterone in the community have ever had their testosterone levels drawn a single time. So they're being treated for a disease that they don't even know that they have. Testosterone deficiency is very, very common. 40% of men over the age of 45 do have low testosterone, and that number increases with age. So starting at about age 35, your testosterone levels decline between 1 and 5% a year. And testosterone deficiency is more common in men who are overweight, have diabetes, have cholesterol, or blood pressure issues. As a side note about testosterone, again, this is something I'm very passionate about. I would love to talk to you or anyone that you know about this. But these are some of the symptoms about related to testosterone deficiency. I will say the most specific symptoms of testosterone deficiency are decreased spontaneous erections, decreased libido, and afternoon fatigue. Those are things I talk to guys about all the time. But all these other symptoms are could be a sign that you'd have a testosterone deficiency that would be worth exploring. I put a lot of gentlemen on testosterone. I put a lot of men on other medications if they're considering future fertility, because testosterone can be spermatotoxic. That's very, very, very important. But there are gels and patches. There are oral options for testosterone. There are injections. There are pellets. There are auto injectors. There are a whole host of things, all of which I write for and manage in my clinic and would love to talk to you about. Back to the erectile dysfunction. So again, we've talked about this as it relates to stress urinary incontinence, but erectile dysfunction is still, even in the best of hands, even with nerve-sparing techniques, very, very common in men after prostate cancer surgery or radiation therapy. And this is because the nerves that are required for an erection run right along the prostate. So even attempting to spare those in the best of hands, oftentimes they can be injured, stretched, or severed, leading to sometimes permanent erectile dysfunction. So again, erectile dysfunction is very, very common, and it is even more common in men who have had treatment, surgery, or radiation for prostate cancer. Briefly on Peyronie's disease. Most people had never heard of Peyronie's disease. Most people, if you say Peyronie's, they're thinking of like an Italian light beer. But Peyronie's disease, most men have heard of nowadays due to the really good advertising, to be honest, about Xiaflex, with the crooked carrot commercial. So I have guys come in all the time and say, oh, I saw that crooked carrot commercial and I want to know if that's what I have. But Peyronie's disease briefly is deposition of scar tissue inside of the erectile bodies of the penis. So we'll talk a little bit more about penile anatomy, but if you look at a penis in cross section, the bottom is the urethra or the urine tube, and then there are two channels along the top that are the erectile bodies or the corpora cavernosa. Those are spongy, elastic tissues that both engorge and stretch. And so you can imagine mechanically, if you had a tube that was once stretchy that now has a fixed point, if that then engorges again, it's going to curve against that fixed point. So back to the idea of zeros and ones, as you can imagine, related to Peyronie's disease or curvature of the penis. I said that a 1 is that it's not painful for you or your partner, and a 1 is that it's a source of confidence and not a source of embarrassment. So I see a lot of guys who have Peyronie's disease, and they're either due to the amount of curvature they cannot have penetrative intercourse, or due to the embarrassment that it causes them, they can't have penetrative intercourse. And both are very serious issues that we deal with all of the time. Peyronie's disease is also an independent predictor of erectile dysfunction, and vice versa. Men with erectile dysfunction are more likely to have Peyronie's disease. There are options for Peyronie's disease, and again, as a specialist within men's health, this is something that I frequently talk to patients about. The options are injection therapy, that Xiaflex, that's the crooked carrot that we discussed. And then there are surgeries. Surgeries are to straighten the penis and oftentimes involve the use of a penile implant that we're going to talk about more at length here in a few minutes, to both provide some straightening of the penis as well as to allow dependable erections again. All right, now let's talk about the fun stuff. So this is, if you have this problem, what can we do? What are the options? And again, my goal is to get guys from a 0 to a 1. And I want to do that in whatever way works best for those patients. So again, it calls back to that slide that we talked about earlier about who can treat stress incontinence, who can treat ED. Many general practitioners in the community, family doctors, primary care physicians treat erectile dysfunction and do a great job. They typically, their level of expertise ends when the oral options end, and there's still many options to discuss at that point. General urologists do lots of erectile dysfunction as part of their their purview of medicine and what they do day in and day out. And then again, within urologists, there's a subset of urologists like me that have specialized training and interest in prosthetic urology. And me specifically, with specialty and focus in men's sexual health, this is something that I talk about all the time and am very comfortable talking about all of the potential treatment options. So these are the erectile restoration or ED or erection fix options for you. We'll talk about each of them briefly. So oral medications, most people have heard of this, the little blue pill, Viagra or Cialis. These are oral medications that are taken that improve blood flow to the penis, making it easier for guys to obtain and maintain an erection in order to have penetrative intercourse or to use their erections. Importantly, a lot of guys, it's not like the movies. A lot of people think, oh, if I take this pill, I'm going to have an erection immediately. That's not true. It still requires sexual stimulation. And the pills have different formulations. Some are shorter acting or longer acting. Some require food to be taken. Some require them to be taken on an empty stomach. And they, for some men, are great. I would say in my practice, I know that the slide says between 50 and 85%. I tell guys about 50% of men that I see are able to go from a 0 to a 1 by taking oral medications. And again, they can be great for some men. They can be very frustrating for some men. It does lack some of the spontaneity of a natural, healthy erection that most men had younger in life. These are some of the side effects. And again, this is something that, because these are serious medications, this is something that needs to be discussed with your physician or provider. Briefly as an aside, I get asked often, well, what do you think about like Blue Chew and these companies that are direct to consumer oral options for erections? I just caution people that this is a serious medication. One of the scariest side effects of any of these treatment options is priapism. So, in the Viagra commercials or the Cialis commercials, they say, if you have an erection lasting longer than 4 hours, you need to seek immediate medical attention. I tell patients all the time, as fun as that may sound, I promise you that is not something that you want. It requires a surgical takedown, extraction of blood and needles and knives, and it is not something that you want to mess around with. And I'm not saying guys who take a Viagra recreationally are going to have that, but it certainly increases the likelihood of that happening. So I caution guys about taking that. And again, often guys who may need some of those oral medications, the first step on their pathway should be to establish care with a primary care doctor to kind of see if there's some underlying problem and make sure that that is actually needed. So a vacuum device, this is just a hollow plastic tube. It's a mechanical thing. It allows blood flow to enter the penis and then often requires a constriction ring, which is elastic or stretchy, placed at the base of the penis that helps maintain that erection. This is, I call this slide into question, but patient satisfaction is high initially. I would say initially, meaning the first time that you use it. And I would say less than 10% of the patients that I put this on use this as a lasting option. So while it's presented here, it's not a great long-term option for erections. These are some of the common side effects, most notably that it can be painful. You can have bruising. It can stop the ejaculate from coming out. Most men really struggle with this. I think of a vacuum device more as a means of maintaining penile length after a prostate surgery or other surgery. So this is probably the second most common thing that I recommend to patients. This is intracavernosal injection, ICI. Most guys have heard of it as Trimix or edX or some other form. What it is it's a needle that you put directly into the side of the penis about 15 to 20 minutes before you want to have an erection. And it is, think of it as locally acting Viagra or Cialis. It's a liquid, locally acting Viagra. What you do is you put the needle in. It's a tiny amount of fluid. You put a needle into the side of the penis, and then again, requiring stimulation, you have a good dependable erection for some men in about 15 to 20 minutes. This diagram over on the left side of the screen shows, again, that anatomy that we had discussed, where the urethra is there at the bottom, about the 6 o'clock position. And then those erectile bodies are on the top, paired structures that run longitudinally along the penis. So I tell guys, I think there's good data to back this up, that about 60% of men are able to go from a 0 to a 1 erection when it comes with injection. The thing that stops guys is penile pain, scarring, bruising, curvature, or priapism, which is that prolonged erection. So this is an option for some men, and for a lot of my patients, this is not a good option. I tell people all the time, it's not really the most exciting thing when you're in the mood to put a needle into the side of your penis. And I think that that's true. So this is not mandated, but this is certainly an option for some men. And unsurprisingly, at 5 years, less than 10% of guys are still doing injections due to some of these side effects. So this is, in my mind, the gold standard. This is the greatest surgery in the entire world. This is the surgery that makes my patients the happiest. When I see patients 6 months after I put an implant in them, they say, without fail, this is the best decision I've ever made. I wish I would have done this 10 years ago. So there are great things about it. We'll talk about some of the negatives about it. But what an implant is, it's a surgical intervention, and it is again, a device. It's a mechanical device. It's a surgery, a small incision that places 3-part system inside of the genitals. So there's a pump that's down in the scrotum. There are cylinders that go into those erectile bodies of the penis. And then there's a reservoir up in the abdomen that holds the fluid when you do not have an erection. So in order to get an erection, the cylinders that are in the erectile bodies of the penis when you're flaccid are just sitting there. You would pump a pump, and what that does is transfer fluid from a reservoir to give you a rock hard erection when you want it. 98% of patients are able to go from a 0 to a 1 with an implant. And unsurprisingly, the partner satisfaction rate with this is also in the high 90s. It does have side effects, like we talked about. Pain, it can be difficult to have bruising, pain, and swelling in the genitals after surgery. And if the device gets infected, it unfortunately has to come out. We'll talk more about that. And then because it's a mechanical device, it can malfunction or lose the fluid. And typically the devices last about 10 years. So here's an animation similar to that sphincter animation from before. So this is going to show that, again, the device is all self-contained. No one has to know that you have it in. It is all hidden under the skin. If you were showering next to someone at the YMCA, they would not know that you had this in. So this demonstrates that when you pump the pump down within the scrotum next to the testicles, it transfers fluid from the reservoir up near the bladder into the cylinders, into the erectile bodies of the penis. And then when you're done, when you want to be flaccid again, you push a separate button, and that allows the fluid to transfer back from those cylinders back to the reservoir, so you're flaccid and no one knows that you have it in. This next video is the same thing again, but this is actually an implant demonstration performed by another high volume implanter out in California, Dr. Cartman. And this is a real patient with a real implant showing that it is a discrete solution that is self-contained and no one has to know that you have it in. So this gentleman has an implant in. There's a pump. You can see, again, you can tell, no one can tell that it's there. he is isolating his pump and he is pumping up the device. It takes about a minute to pump all the way up. It varies how many pumps it takes, kind of depending on how hard you squeeze and your experience with the device. So now he's going to show that the device is fully inflated and he has a dependable rock hard erection. And then what he's going to do is show you here in a second, again, by identifying that button location, he's going to squeeze the button and the fluid is going to, again, go back out from those erectile bodies back into that reservoir. Sometimes guys squeeze their penis to kind of help that process along, but it goes back to a completely flaccid state where he's able to, wear normal pants. It's discreet. No one knows he has it in, and he has a normal flaccid penis again. So benefits of the implant, it's really a cure to erectile dysfunction. It is a permanent solution to ED. It is the closest approximation to a physiologic erection that we have. It's spontaneous. It takes less than a minute to pump up, and the erection lasts as long as you want it to. If you want to have an erection that lasts for 4 hours, you can, because it's no longer a priapism. It's what was once blood-filled is now saline-filled. It has both high patient and partner satisfaction. It does not impact, in most cases, the vast majority of cases, it does not impact ejaculation, orgasm potential, or sensation of the penis. And implants, while it might sound crazy or too good to be true, a lot of guys have never heard of this. They've been around for more than 40 years, and 500,000 of them have been implanted across the world. So again, there are risks. And a lot of these risks, the nuance of them, we can talk more about if I have the privilege of seeing you in clinic. But the biggest risks are, again, the recovery period can be rougher than most people think. The second is if the device gets infected or malfunctions and has to come out for any reason, you can't then backtrack to injections or oral medications. The only option would be to put a new implant back in. And again, the risk of infection is about 1 to 2%. And that's more of a concern in guys who have other underlying things, men who are immunosuppressed or have diabetes. So to summarize, erectile dysfunction is a very, very, very common problem. It is a serious problem that impacts the quality of life in men and in my patients. There are a lot of different treatment options. Penile implants are, as excited as I am about them and think they're the greatest thing in the world, the greatest surgery in the world, they are one of the many options that can be considered for erectile dysfunction. I just happen to think it's the best one. So if this sounds like something, erectile dysfunction in general, that you want to talk more about, I would encourage you to talk to a loved one, a partner, and then talk to a specialist, your primary care doctor or a urologist that you see, or better yet, come see me and I'm happy to talk to you about all of these options. So this is, again, my information, my cute picture. This is my office address and my care team's phone number if you wanted to call to get an appointment to talk about any of these options. And I would love to take the opportunity to answer any questions that y'all have. And I really, really, really appreciate your time and your kind of open-mindedness, because this is, again, a topic that can be tricky to talk about. And I appreciate you being willing to entertain the idea of getting help if this is a problem that you experience.